know that that will come through. And so let me get the PowerPoint on and ready to go. And this has a different aspect ratio, so they'll change that in the back. And then this is
perfect.
Thank you, John. And you'll see when Ken starts, he needs no further introduction.
So I stand here and look out at this amazing group, and I'm very humbled to be here in front of you today because there's a lot of people extremely talented that are in the audience. I don't consider myself one of them, but you're going to listen to me for a little while here, so that's great. So just a little introduction. The Grand Canyon is on my bucket list to backpack down in and out of. Highly recommend it. It was an amazing experience. The upper right is I do some snow skiing up at Tahoe. That's the top of KT-22, looking back over Lake Tahoe one day where there's a complete inversion layer. The bottom left is my dad, who will be 97 this year, helping me in my little backyard vineyard with our harvest. I get about a ton of Pinot every year, and I'm now the winemaker also in my spare time. My parents in the middle. Little summer place in Lake County. That the good news about all the smoke we had, you get some amazing sunrises. And then my family, both my kids and my wife. And the good news about both kids is they're employed. So we're going to move in today's topic, and it's lessons learned from Kodak. So back in 1984, after I had gotten out of school a couple years, I wanted something outside of dentistry. I was kind of an associate for my father, and didn't get to make many decisions in the office. So I went into the one-hour photo business. I became a franchisee of One Hour Moto Photo, which was the largest independent franchisee and film processor in the US at the time. I had 2 stores in Northern California, processing film, about 20 employees, and we also had portrait studios in both stores. In 1987, I was franchisee of the year, and I used to go to the Photo Marketing Association meeting in Las Vegas every year. And at the beginning, it was all about film, but as time progressed, the word digital started to come out. But the feeling at the Marketing Association was the cost of the cameras was so high that it would be a very small minority of people who would migrate to the digital world, and that the film industry could keep the resolution of film growing faster than the camera resolution of digital. So no one really thought it was a threat. So in 1996, Kodak had 2/3 share of the world film market. They were the 5th most valuable brand in the world with a 30 billion market cap. By 2012, Kodak had gotten out of the film business. And why? Again, the digital camera. And what they didn't think about was Moore's Law. So they couldn't keep up with the resolution in film. So I'm going to go on a kind of a little tour of the evolution of digital in my office. And we'll start with just communication. So what I'll do is I'll take my Kois series of photos and put it into a PowerPoint. I'm a Mac person, sorry Mark, but I'm a Mac person. And then I'll take that. This is a young female, early 30s. So we turn the volume up just a little bit.
She just came out of Invisalign, done by...
So this is what I send to the lab when I want a design done.
But she'd like to fix the front teeth and have them look better.
I think that if the lab has a real person in front of them, so to speak, they can relate to it better and see what I'm trying to accomplish.
6 is at cuspid 0, so we just need to fix the anterior 4. If we look from the lateral, you can see the badly discolored resins that she has and the wear on the cuspid.
So in Keynote, I can just do a voiceover.
Teeth apart.
And if my lab has a Mac, then they can just listen to it. If they don't, or I want to work with one of my specialists and do the same thing for the orthodontist or the periodontist or my implant surgeons, is I'll do the same thing for them so they have an idea of what I'm looking for before they see the patient. Then I can do the voiceover and I can export it as a QuickTime movie, then anybody can look at it. They don't need a Mac.
Facial embrasures whatsoever. and 7 is already a little prominent, so we're going to bring 8 and 9 facially. Again, with veneers. 7, we're just adding a distal incisal resin. So we're just going to improve our embrasure form with 8 and 9. Here we have our face pose. So you see she's pretty level.
So I don't fill out lab tags, I do this instead.
And everything is good as far
And
as...
also, if I'm in the middle of a case, when I do my provisionals on a larger case, again, I'll do a set of photos, do a voiceover on those for the lab also.
Use reference points to bring in close-up.
I do use
And
templates.
smile curve
On
and
this,
80%
I do.
centrals. And that should look pretty nice if we drop those down to that curve. 7 is doing okay, so we'll leave it well enough alone. And 10, I'm just going to have you just wax the distal so I can make a matrix and do that in resin. We need to do a little gingivectomy on 8, but I can freehand that one, so we should be good there. Again, smile curve, and this is what it should kind of look like at the end for us. This is what I envision, and then again with making the facial embrasures, so we're bringing out 8 and 9. Look forward to the case. Thanks.
So that goes to the lab, I get back my design. Normally it's a digital design that they send to me, so I 3D print it in the office. Do my E-lab for shade. And then we have the case. We have our pre-op, we have our provisionals. The time of provisional, I did the composite on number 10, and then our final. Again, you're going to see most of the ceramics are done by Wanda Nelson Rigo in this entire case, in the type presentation. So I also use it in decision making. So this is a patient that comes in with a large diastema, and I look at it at the get-go and go, ooh, pretty good sized diastema. Not so sure I can close that. Maybe orthodontics to split the space, or 4 veneers and mesialize the teeth. How am I going to do this? So, but I throw it on my computer, I put on my little template, and that's my 80%, which is kind of the sweet spot in central size, and I'm touching on the midline. So I'm feeling pretty good about just doing a diastema closure on this. So I go ahead and do a wax up, traditional way, make my lingual matrices, and do some layered resins, and close my diastema with resin, completely additive. So again, our pre-op and our post-op. And again, having predictability of what I'm going to accomplish before I do it. And again, the patient who came in and left and was pretty happy with his new look. The next thing is injectable resins. Young patient, 18 years old, comes in, found me through my website, and she goes, her mom's with her, she goes, she's heading off to college, she feels embarrassed by her smile. She'd like to do veneers. And I look at these teeth and go, they're spectacular teeth. They're beautiful. What nice texture, what shape. They're gorgeous. Arch form's not too great, but not a filling in her mouth. You go, you need to see the orthodontist. I'm not doing veneers. You need ortho. Mom says, no, we want veneers. And I'm going, no, you want ortho. And we go back and forth. So mom says, well, we've seen orthodontists. They won't treat her. And I go, well, you need to see a different orthodontist. And then she sends me this, and there's no roots on the centrals. So she's afraid the orthodontist didn't want to touch the teeth for fear that there would be no centrals. So now we're back to veneers. So with injectable, the steps are an iOS impression, the lab doing the design and fabrication, and they'll make 2 models. They do the full design first, then they can just delete every other tooth, fabricate another model design. They'll fabricate 2 clear matrices for me, or that way you can fabricate them yourself if you like. And then you're just going to do your regular bonding protocol, isolate, particle abrade, etch bond, and then injectable resin and polish. What's your cost? Your cost is your lab fee for the design and matrix. And your time is the initial iOS impression, then for me about a 2-hour appointment for bonding. And then I always do a follow-up appointment because I've always missed something that first day. But it also is a reason to bring the patient back to make sure they come back for me to get final photos. So again, our pre-op model, our every other tooth, and our every tooth design. The matrix of on half the teeth, and then the clear matrix on the entire design. If you look at this, you can see how far I'm bringing the laterals facially, which kind of came back and bit me a little bit in the final. But this is totally additive.
Wow.
With flowable resin and injectable technique. Number 7 is a little lower value because of how far facially I brought it. And I probably should have put a dent and shade underneath there to mask that out. But you learn as you go. And again, designs by Rigo. The next thing is custom implant abutments. Betsy showed some of this the other day. But coming out of COVID, I was talking to Nelson and said, hey, let's try something different. I don't read, I guess, enough journals to know other people are doing things, so I just started experimenting on my own. But this is a case that was post-extraction. I did socket preservation, took out the tooth. She was in Essex, came back, so that's our pre-op. I placed an implant, guided surgery, put on an immediate provisional. And then she disappeared for about a year. Her husband had a lot of health issues, and they had some financial setbacks. So she finally came back, and I go, well, my color's not too good on my provisional, but I really like the tissue profile. So we decided to move ahead with the final. So again, we take our E-lab for our shade. And in the analog world, when I'm trying to mimic and capture that subgingival profile, there's quite a few steps for me. I have to remove the provisional from the mouth, mount it on an external analog, flow some sort of material around it to capture the form of it. I mark the facial, I remove it, put on my pickup post, syringe material around that in the gap that I've made, cure that, mark that, transfer to the mouth, and take an impression. So there's basically 7 steps. And I go, well, in the analog world, in the digital world, we can scan the mouth with the provisional in, remove it, scan the soft tissue, put in our scan body, scan that, and then take this provisional, mount it on analog outside the mouth, and scan it independently. So again, in the analog world, this is 6 of my 7 steps. In the digital world, these are kind of the 4 steps. So again, we take that independent scan with the provisional outside the mouth. That's then merged in 3 shape into the mouth. You can see the exact subgingival profile that I've created. The lab transfers it to the implant analog and then creates a wax up to duplicate it. At least the subgingival part, they'll have to add length incisively and make a few corrections there, but it's the subgingival that I'm trying to get. They do their cutback, their final design, and then it comes back to me. This is not the same case, but the same thing used on this. So this is a provisional. You can see it's from a printed model because you can see the print lines in it. So I'm removing the provisional, and oftentimes in the old days, the analog, I would take this out, put it in, see a lot of blanching, or see a gap around my final going in, which means I didn't have the same support. So we slide this in, no blanching, drops right in. You'll see when the screw goes in, there'll be a little bit of pressure, so a little circular fluid, so to speak, will come out. So I feel I'm supporting it exactly the same. And we've probably done about a half a dozen of these at this point, and they're all working really nicely. So it's a very nice technique and dramatically faster. So this was the case, her final smile and close-up. So again, I think we maintained the tissue architecture that I was able to create in the provisional, and she was happy and I was happy. Again, ceramics by Wanda Nelson. So the next is a fiber-bonded immediate bridge. So in my analog days, so to speak, this is a patient that's bruising number 25 from periodontal problems. So I take a putty matrix to help reposition the tooth, extract the tooth, and then use rib bond on the backside to put her tooth, after I ovated it, right back into the socket, and use that. Normally it's a short-term provisional. What I found that these actually hold up pretty well until the rib bond started to break down and fluid got in it. You can see the pre-op, immediate, and post-op, and it's their tooth, so we always get a nice shade match. So this is a patient I had in earlier this year, referred by a periodontist. Seen an endodontist, the tooth wasn't savable, wasn't retreatable, so we're going to take it out. We don't know if we're going to lose the other central next to it. We're going to take out the one first. She's actually going to do the extraction, then have the patient drive over to my office to go from there. So we have a pre-op impression. I sent it down to Nelson and said, hey, let's try something else. I want a matrix, because my putty matrix, the tooth always kind of floated around it. I had an incisal edge reference, but it never really grabbed the tooth well. And if I had covered the facial, I wouldn't have trusted it to tap it from the lingual. So we had this designed, he sent it back to me, I printed it, we kept the lingual open so I could get to the lingual to tack. So what's the cost on something like this? Well, it's about $40 for design. I switched to Dentapreg from Rib Bond, and I like the Dentapreg material a lot better. About $210 there. What's our time? The iOS pre-op scan, and then the tooth modification and splint placement takes me about an hour. I'm not very speedy. So I'm taking my pre-op model and measuring down to my gingival margin, because then I'm going to want to measure and transfer that to my tooth and add 3 millimeters, as Betsy showed yesterday. So the surgeon luckily didn't throw the tooth out, sent it over to me. We're going in modifying the tooth. And again, not this fast, this is sped up a little bit. Particle of braid, got cotton over the extraction site to protect it. Little GBT to make sure I got things as clean as I can. Try in the stent that was printed, fit perfectly. Remove the sutures, because I want to put this down into the socket. We had a little bit of bleeding, put a collagen plug in. Went ahead and etched. It was rinse, bonding agent, dry, then all the steps. Initial light cure. The tooth I actually tacked into the stent with super glue on the facial to hold it. Dropped it in the socket, tacked the lingual, and then removed it, and then put in my Dentapreg, one tooth at a time. And there's a light layer of flowable over the top of that, so it's smoother to the tongue. They are a little bulky, so you have to warn the patient about that. And then I come back to polish the facial and put a little bonding on the facial just to help lock the tooth in. And that's our final. The patient basically had her tooth in the morning, so the surgeon had her tooth in the afternoon. So again, our post-op photo immediately post-surgery. So again, this is our pre-op and our immediate post-op superimposed over the top of it. So we've recreated right back to what she had walking in. The color will come back, as you all know, as soon as it rehydrates. I couldn't get her back to see me for the post-op, although I tried. So I had the surgeon take a photo when she was back seeing the surgeon, so our pre-op and our post-op. So facial margins looking good. We did lose a little bit in the pupillas, but maybe that'll come back a little bit. But still a very inexpensive way for her to get a tooth. Again, not knowing what the next tooth is going to do for now, and give her a nice provisional. And I started doing these as provisionals, but I have them now, a lot of them in as long-term restorations. They've been 8-10 years. So the next is Smile Cloud. Florin Kofar in Romania pretty much developed this. He came out to my study club a couple years ago. He gave an amazing presentation. So I use this for step 1 and step 2. So we have a patient in that I still take my 2D photos. So we're looking at repose. We're seeing a little bit of lower tooth. Upper, we're not seeing any, so it's like, oh, we can lengthen these a bit maybe. We do our close-up photos. This is about a 45-degree angle back. So I'm seeing a little more lower, but it's telling me maybe we don't want to lengthen the lowers, but we're just seeing the uppers, so maybe we can lengthen the uppers, but then I look at the full smile, and I've got long, skinny teeth. So, and I don't see a great way of being able to widen them. That's who he is. So I really don't want to lengthen the centrals, but I'm going to, because he's a CCP, I need to open vertical, and I'm going to do that by increasing the posterior height. Again, you see the amount of overbite that he's got, and he's wearing out the backside of the centrals, and he's kind of an edge on the laterals. So again, we're going to keep the length on the centrals and go from there. A lot of acid problems. We tried to follow up with an ENT. We did place an implant on the upper where the primary molar was lost. But bring him into Smile Cloud. And again, John showed this the other day. So I can orient the face, because I already know that from the Kois glasses. I outline the lip form. And then bring in the template, and you can change the size of the central, you can change the embrasures, you can change the distal, and you can change the arc of the smile curve. Either it'll move bilaterally or you can move it unilaterally. And then once you have that where you want it, you go ahead and use the AI that they've developed to import what they think are teeth that are going to match this face. And you can click through different ones and see which ones you think you like better, or get him back to where he once was. You can flip and match the centrals, because oftentimes the teeth are not aligned. You can change color, and then you can share this with the patient if you want. So again, the time for me to do this is normally less than 5 minutes, and they'll do a full arch wax up, send you back an STL file at $12 a unit. And they did the wax up on this one. So again, just to show, you can use the slider to see that I did not change the length of the centrals, but we increased the length of the posterior. So again, centrals are exactly the same length. So again, his case was his before the Smile Cloud design. We did have him send back a wax up for a trial smile, just because his personality, he wanted to see it in his mouth. And then we did the provisionals, and then we did the final, which was the full arch upper, and all the lower posterior teeth because of the acid destruction. The lower anterior 6, we just did resins on the incisal edges. So DSD, I met Christian quite a while ago, had him again out to a study club, kind of before he became famous. But this is for steps 1 through 4 and 6. So this is a patient that came in, again, quite a few old crowns. Area was fine, but not happy with the way things look. Multiple colors, doesn't like the shape of her teeth. Some TMJ issues, and again, some CCP. Failed tooth number 29, implants going in there. I didn't like the tooth arrangement. I didn't like the plane of the lower. So she went off to ortho. We removed actually the lower veneers so that the orthodontist could align the teeth better because there was too much compensation of the teeth with the veneers. So this is post-ortho. She opened spacing for me to be more ideal. Took photos, sent it to the hub, used that information to go to DSD and had them design the upper to ideal for me. Again, my goal is to somewhere always to be around an 80% central if I can. But the orthodontist aligned the incisal edges as opposed to the soft tissue for me. So now I need to do tissue modification. So they've outlined how much I need to get symmetry in the case. We also need to restore the lower arch. So again, the design there at the vertical we decided upon. So we get back our crown lengthening guide and design, and it was about $217 for that. The cost of DSD just went up, and DSD has got a little more restrictive. You now have to be either a DSD clinic, or you have to be en route to becoming the DSD clinic to be part of their program. So I printed it. I left the build platform on it. There's a nice little handle to take it in and out. I tried it on my pre-op model, and it's like, well, that looks exactly what I want. Tried it in the mouth, mimicked what was on the model, so I'm feeling pretty good following it. Because in digital, you're only as good as the design. So I have an erbium YAG in my office. I know John does this beautifully with a scalpel and has this beautiful ability to take it and spin it in his finger and get a beautiful architecture. I don't have that ability with a scalpel, so I use guides. So I'll come in at one setting and do my gingivectomy, check my depth, and I'm not at 3 millimeters. So I can come in with the laser, and the cladding on it actually is right at 3 millimeters. So all I have to do is take it up to the cladding and kind of go line to line angle, and then reconfirm that I have that. So I'm going back, getting more length at the line angles. And when I do these with the laser, I get very little bleeding, and I'll go in and take final impressions the same day. So this is the day I'm prepping the full arch up on top. I normally do anterior 10, upper 10 one day, and come back the next day and do the lower 10. I used to try to do it all in one day, but I'm too old for that now. So confirming line angle to line angle. And then I'll also use the laser, a different setting, for removal of the veneers, because then it's coming off right at the cement interface. I'm not guessing as when I've through the veneer and into the tooth. You'll see in a second, you'll see the residual cement that it leaves on the surface. So I'm right at the interface, and then I can go from there. So this is just x-ray of our upper 10 over lower 10 with the implant in, and we came back and did the molars. But again, our pre-op, our post-ortho, and the completed case. A repose of the same 3 photos. And our final of the same 3. So this is case number 8. It's kind of an interesting case. Referred to me by a periodontist, some pretty severe perio. The periodontist feels the case is going downhill and wants to see if we should be transitioning to implants before she runs out of bone. So again, we do all the same workup on every patient. I have an older patient base, relatively small, and I go through the Kois photo series on every single patient. And normally, again, if they're going to do extensive restoration, I put it into a keynote and run through things with them at their second appointment. It's just how I do it. Oftentimes when I'm doing the keynote, I see things that I've missed in the exam. So at this point, I've added Insta-RESA in my protocol. So this is her existing bite, is the blue, and the white is the design. So her anteriors are flared. We want to bring those back a little bit to create a nice class 1 for her if we're going to do an upper lower. As we look a little closer at her pre-op bite though, we see she's got an anterior open bite. So is this an airway issue? Is it a TMJ issue? I haven't made that determination yet. It was something we need to follow up upon. Because our plan is to close it. So again, pre-op, design, so we're closing that. So that means we're going to be modifying P3. So I have John in my office. He sits up on a cabinet over me every day. And when I have questions, I ask John. So I asked him, should we test drive our P3? He said, yeah, I think we should. So I went to the lab and said, I want to do a mock-up. I want to do the mock-up on the lower, but I want to do the palatal mock-up on the upper since I'm bringing that back. So again, in the digital world, they can cut off the outside and give me the inside. So we put that in the mouth. So you can see we've increased the length of the lower anteriors to where they would be in the future. And you don't really see much of a mock-up on the facial. I put wax in between to try to lock in all of her embrasures. And then we did the 200 micron paper, that or chew around on it. And I'm not getting a whole lot of strikes. So I'm feeling pretty good that we can go ahead and go to this P3 on her and feel good about placing implants based on these positions. So our last case is Insta-RESA. It's everything, it's all 10 steps. So this is our patient, smile she once had. And this is where she is today. Pretty high risk area, in case you haven't noticed. Thought I'd point that out.
Oh.
She does tell me she flosses. That's what the little line down the front is. The upper molar is held in by an calculus bridge. So I referred her this to the specialist I work for all my implant cases, and we went in and actually removed everything but 4 teeth on the top, 4 teeth on the bottom. I needed something as a reference to build the design to, and also to try to hold the vertical, and to get it cleaned up a little bit, so that the day of surgery there'd have to be less cleanup. So again, I do my 2D design, I do my voiceover, I send this is Allure Lab down in Tracy, California, who did the design for me. Is they're familiar with the Insta-RESA protocol. So there's our 4 teeth. Lab doing their design work, bringing the design. You can see I wanted to shorten off the cuspid. And they've shortened it exactly the way I wanted it to. So they're actually following my directions, so it's nice to see. You can subtract off the face so you can check what it looks like. The occlusion on the teeth themselves. And then we can bring that into our CBCT, that design. Figure out our implant placement for the upper, with a reference pin in the palate to come back and scan to. Same thing on the lower, plan our lower. And this was our pre-op, our design, and 3 days post-surgery. Full upper, full lower. So she was very happy with the result, super happy when I showed her this. Showed her husband first, and he was kind of saying, oh wow. She looked at it and started crying. So we're now at kind of our final test before our final zirconia. So we just put in the full upper lower about a week ago. Zirconia actually is being fabricated and coming back. So we got to change her life completely. So kind of to sum things up is, I've been talking about digital, but is analog still needed? You still need to keep your polyvinyl around. And the answer to that is yes. I still need it for removable. I still need it on veneer cases where I'm not breaking contact. I need it for no prep cases sometimes. So there's still a time and a place to have it, and to have it as a backup, because sometimes the digital isn't quite doing what I want the digital to do. But don't be Kodak, okay? Digital is now. You saw that 2 days ago, you saw it yesterday. So using our Kois Foundation, we're only limited our imagination on how to expand its application. So if you're not doing it, start doing it. Start think where can I add this in my practice? I'd like to thank John for having the confidence in me to put me up here. Betsy says she doesn't talk to large groups very often. I never talk to large groups. I'd like to thank Doug Thompson. I took his wellness class 2 years ago and I wasn't too well. A lot better now. So thank you, Doug. I'd like to thank Juan and Nelson Rigo for their amazing ceramics, but more importantly, their 20-year-plus friendship. And Dr. Nerles and Bynum for introducing me to Insta and how they're bringing us along that pathway. And this is a vertical of my wines that I make, and I've got 2 more to add to it, so thank you very much.
How could you not know? So honest. I think you can't not be impressed with someone that's been able to really master principles, but stay so versatile, stay so fluid in your practice over the years, how you've transitioned, and that Kodak to digital analogy couldn't fit better. I think this would have been a great presentation to end the symposium, because he put the whole symposium together in one presentation, taking you through his cases, but more importantly, I feel like you took us through a little bit of a journey through your life and your development in this profession, which is, I think, very, very helpful to all of us. If that's not, you can't not be inspired by that.
Thank you so much. Thanks.